Hey, good morning. It's Wednesday, May the 25th, and I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. This is National Senior Health Day. That includes me, unfortunately, now. And we decided to take a look at a condition that's affecting more and more seniors, Alzheimer's disease and dementia. You may recognize these two famous Americans, former President Ronald Reagan and singer Glenn Campbell. I would do a Glenn Campbell song, but nobody would appreciate that. Both died from Alzheimer's, and they both chose to share their diagnosis with the public in order to bring more awareness to a condition that is sometimes called the long goodbye. Today we'll focus on all things Alzheimer's with leading experts on research and treatment. We'll also show you a simple test you can take at home to see if you might have the beginnings of this disease. And we'll check in with Dr. Dana Hawkinson for our latest COVID numbers. So make sure to get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find those links right here on your screen. With us this morning is Dr. Jeff Burns, co-director of the KU Alzheimer's Disease Research Center and a neurologist at the University of Kansas Health System. Also joining us by Zoom is Michelle Needens, a social worker and director of the Cognitive Care Network. Good morning to you both. Okay, guys, so why is Alzheimer's called the long goodbye, Dr. Burns?
Yeah, well, it is often called that, especially in the press. And the reason is it's a progressive disease that continues basically over a course of about 10 to 12 years until somebody dies. So it's a slowly progressive disease that just moves forward without, an ability to stop it until somebody passes away from it.
That has to be one of the most frightful diagnoses to receive. And I bet your patients, when they first meet you, they're looking for hope, but it's hard, right? I mean, there's not a lot of new effective therapies out there, and things are sometimes very difficult. Help us understand what's the difference between normal age-related memory loss and Alzheimer's.
Yeah, well, I mean, that's a big question, and that's one we deal with every day in the clinic when we're seeing patients with Alzheimer's disease. So what's the difference between normal aging and, when do we get worried? We all have memory problems. We all have memory lapses. We might misplace our car keys, our glasses, and that's something that happens our entire life. When we see the beginnings of Alzheimer's disease, it's a new level of forgetfulness. So it's families noticing, somebody's forgetting things that they used to not forget. They're misplacing the tax documents when they used to be obsessed with it. And so it's a real change from sort of the usual types of memory lapses that we have. And so when actually the dividing line, which I think we'll get to in a second, is when it starts to interfere with daily function, when it starts to really get in the way of the things that somebody usually does, that's when we start to get worried.
Yesterday, I think the nurse who I've worked with for 18 years, Joyce Funk, I think she looked at me like, what is wrong with you? Because I couldn't remember what she had just said. I also suffer from a little bit of ADD, and if I don't pay attention, that's a little bit of a struggle. How do I distinguish some of those features where, okay, was I just not paying attention, and therefore I don't remember, or I just don't even remember anymore?
Yeah, I mean, distraction's a big cause for memory lapses. So, if you got a lot on your mind and you're juggling lots of things, then it's common to sort of let things lapse. And that's not something that we really worry about, that type of memory lapse. It's more, forgetting a conversation 10 minutes ago or yesterday and having the same conversation over and over again. It's lapses like that. Forget it, we all have trouble coming up with a name of somebody. Maybe we know them pretty well, and it might take a second to come to us, but that's normal. It's the completely forgetting or family members who having more difficulty. So it is sort of a continuum, but we tend to in the clinic we're able to sort of parse and think about that sort of distraction, that's sort of the tip of the tongue syndrome versus real changes that are beginning to interfere with daily function.
Yeah, since I've not been able to remember names my entire life, I'm hoping that's not a real change. So I'm relieved to hear you say that. What's the difference between Alzheimer's and dementia?
Yeah, that's the number one question that we get, and really the short answer is Alzheimer's is a specific type or cause of dementia. Now, taking a step back, dementia is just a broad term that simply means memory changes that are interfering with daily function. So cognitive changes, memory and thinking changes that get in the way of doing the things somebody has been able to do their whole life. That's dementia. It's a syndrome, and it's fairly easy to spot when we're sitting down with the patient. And after we sort of spot it and diagnose it, then the question is what's causing it. And Alzheimer's is one of many things that can cause it, but it's the number one cause by far. Probably 2/3 of all dementia is caused by Alzheimer's. And how do we define Alzheimer's? Well, it's the presence of amyloid plaques and tangles in the brain. So abnormal buildup of these proteins, amyloid plaques and tangles in the brain. And so when we're making a diagnosis of Alzheimer's, we're predicting the presence of these amyloid plaques and tangles in the brain. And we're pretty good at predicting their presence, but so Alzheimer's specific cause defined by plaques and tangles in the brain, specific cause of this bigger syndrome of dementia.
So that's a good explanation, so thank you. I'm going to say something back. I want you to comment on it. So if my normal memory loss, my memory is getting worse and worse and worse over time, that kind of happens to all of us as we age. But it sounds like Alzheimer's kind of takes off and escalates, and then you figure out about these whole tangles. So first of all, is that a fairly accurate depiction of my little hand motions here? Is that pretty good?
I think, yeah, not bad.
Not bad,
Yeah.
okay. That's for a pulmonary guy. All right, so then what about these tangles? Can you find these tangles on a scan or anything, or is it something you figure out because of all the testing? Or tell us how you figure it out.
Well, that's a great question. So, and the answer is, for the last 120 years or so, we were predicting the presence, meaning we had to look at the brain under the microscope after somebody died.
So that's not a good way to make a diagnosis before death then, right?
No,
we don't
not
like
at all.
that. Yeah, okay.
No.
Good.
And in the last 10 to 15 years, there's been huge advances, big steps forward for imaging tests, PET scans that allow us to see amyloid plaques and now tangles in the brain. And that those are still sort of mainly research-based, but they're becoming more and more accessible, and we'll probably start using them in the clinic more and more over the next few years. But spinal fluid testing is another way that we can detect the presence.
Let's get a better way than that, though.
That's sort of the gold standard right now. And then in the next couple of years, we're going to see big advances in blood biomarkers. So we're now able to actually, on the research side, measure amyloid plaques and tangles in the brain. But it's still research. It's not quite precise enough to sort of use in practice, but that's coming.
So what's causing all those tangles and stuff?
Well, that's the big question that what causes Alzheimer's is a big question. And there's lots of theories, and we still argue about it, what's causing it. Amyloid plaques build up abnormally in some people with age. And there's some people, that sort of the dominant theory is that those amyloid plaques trigger the tangle buildup and the cell death that we see in Alzheimer's disease. And so that's one theory, but there's many others. There's vascular changes in Alzheimer's disease, there's metabolic changes in the brain in Alzheimer's disease, and we think that's a big unrecognized part of the disease that our scientists are really leading the world on understanding. How does metabolism and brain changes within the mitochondria influence the disease? So lots of theories, and not a lot of clear answers yet, even with all the research we're doing. But at the same time, I'd say it's really hopeful time. There's more going on in the field than ever before, and I think we're going to get there, but it's a matter of when.
It feels like this is a big problem with Alzheimer's. We read about it more and more, and you seem to see more patients. Is that just because people are really get to be old, or is how big of a problem is this Alzheimer's thing?
Well, it's a big problem. And actually what's driving that is we're living longer, healthier lives, which is great. But along with that, because it's such a age-related disease, and our risk goes way up as we get older. So when we're 85 and older, about 1 out of 3 people have Alzheimer's disease. And so as the size of that population grows, just that statistic, that 1 out of 3 are have Alzheimer's and therefore at very high risk, we're seeing a big increase in the numbers of people in the United States, around the world, in Kansas and Missouri, go up, just because we're living longer, healthier lives, and we just have so many more people at risk of this age-related disease.
So my answer to the question, Dr. Burns, why are you here? Get back to your lab, because I'm getting close to 80. Michelle, talk to us a little bit about the Cognitive Care Network. What is it, and what its impact been on patients with Alzheimer's?
So in a short answer is that it's an education and support program in partnership with primary care to really move the dial to earlier detection and strategies to decrease functional loss over the course of time in these dementias. And it relates very much to the conversation you and Dr. Burns just had. And that is, the subtle changes and oftentimes we're missing the early diagnosis. And even when people are diagnosed, there isn't magic on the medical side. It is primarily non-pharmacologic interventions that can support a quality of life. So we partner with primary care and provide education on dementia evaluations and support them in doing that in practice. And then we see the patients post-diagnosis rather than waiting till crisis. The impact really is that people are able to grab onto strategies that allow them to cope with a diagnosis that is tough and to see a pathway to move forward rather than to get lost in grief and hopelessness.
Yeah, that's got to be a big challenge to you, that the grief and the hopelessness that comes with the diagnosis. We've probably all know people who have had Alzheimer's, and you watch that long goodbye. What do you do when families come in and they have this symptom, and how do they stay functional in that world? That's got to be so hard, the whole level of support that's required.
Yeah, and my thought about the long goodbye is that it helps us articulate that the loss is not Alzheimer's disease. The loss is the little bits that are changed throughout the disease, that for the person and for the family. And along with that, there's a number of hellos. People can change perspective. People can come to grips and resolve things that were unresolved. People can embrace wellness strategies that support function. People can begin to use their disease for the greater good. What I'm talking about, right, is empowerment theories, are those strategies that help us move forward, even if we have terminal cancer, if we have chronic disease unfixed, that those are the steps that we take to move forward. And it's possible in Alzheimer's disease. I see lots of tough things every day, and I want you to know I see lots of beautiful things every day too, where people can become stronger and learn a different way to function and move that has value.
I loved it, and sorry, I didn't mean to interrupt you there, because what you're saying is so important. And I love the point about, okay, cancer patients go through this and they have a long goodbye, and also and trying to find the good every day and to appreciate those things that it does hand you. I love that thing about the hellos. The pandemic, that had to really affect people with dementia and with Alzheimer's, and your world's even more narrow than what the disease, when Alzheimer's would have presented to you.
Oh my goodness! The pandemic really hit this population very, very hard, and on a number of levels. For one thing, services dissipated. So families going through middle stage and on, who were relying on respite services, companion services to come in, who were on the cusp of or recently placed in long-term care facilities, daycare, day support programs closed, support groups transitioned to Zoom. So services kind of dissipated, and people were left out there very much on their own. I have been in the field for decades, and it absolutely challenged myself and my team. The answers that we were used to giving became meaningless. And we had to find new strategies to support people at home, but very, very tough. The incidence of anxiety and depression, which for individuals in middle stage on often translates to behavioral complications, escalated exponentially. And again, without opportunity to embrace services that might have mitigated that or engagement. Families were isolated. They were afraid to visit parents that were older and more frail. People are not all about technology, so Zoom isn't an answer for everyone. And so that isolation, both depression and anxiety on the care partner side, as well as the person with the disease. And of course, we all saw what happened in long-term care, where families could not go in and visit. So people that had recently placed their loved one could not help them with that transition. And we saw just a nosedive for residents in long-term care. As they couldn't see family and they didn't have the activities that keep them alive. I will tell you, it certainly was it underlined the importance of engagement and keeping people fully connected to living and activities and people, because without that, we saw that absolute nosedive. So services were taken off guard with the pandemic, and we did not get it right. We absolutely did not get it right.
Yeah, that was tough. And then if a family depended on people coming in, and when those caregivers got COVID, then they couldn't come in, and that the whole thing. Pandemics are you know what? They're terrible. and we talk about long COVID, but man, there's a long pandemic syndrome here, and I think it really affected so many of these patients with Alzheimer's. Guys, we talked a little bit about some of the early signs of Alzheimer's. Talk to us a little bit about the different stages of Alzheimer's.
Yeah, so I mean, we talked about sort of that long goodbye, that progression through the disease course. We break. There's a lot of different ways to sort of break it up and think about it. I tend to think about it using the one system that's very mild are the earliest changes, where we're seeing just a little bit of memory change, a little bit of organizing and planning difficulties, sort of what we call executive function, and then so very mild, moderate, and severe, where we progressively see loss of ability to do the things that we always do, and then in the middle stages we're needing a lot more support and care to maintain those things, from taking care of yourself to the things that the finances and those day-to-day activities that we sort of take for granted when we don't have memory issues. And then in the severe stages, somebody needs full-time support to really do everything from going to the bathroom to bathing and dressing, and but those sort of very mild, moderate, and severe is one way to think of the stages.
So we've mentioned before there's not, and you talked a little bit about, there's not really a cure for Alzheimer's. How do you treat the symptoms? And talk to us a little bit about the role of exercise, because you've done a lot of work on funding about that.
Yeah.
Research on that.
Yeah. So one thing I would say is we can't cure it, but we can treat it. There are medications that are helpful. And I think they're important to use. They don't stop the disease, but they can slow some of the decline and some of the symptoms of the disease. And so there's two medications that we use. One that we start in the early stages, most commonly referred to as Aricept, but there's a couple cousins of Aricept, or donepezil, the other name for it. And then we'll add on a drug called memantine or Namenda in the middle stages. And so, I think it's important. Those drugs don't stop the disease, but they can help some. Now, we're not happy with those, because we want to stop it, we want to reverse it, we want to improve things, and those don't really do that. They slow that decline. And we're working on that, and there's a new drug out.
We're going to talk about that.
Okay, I'll hold off on that.
No, let's go there. What's the name of the drug? Aduhelm? How do you say it?
Aduhelm is how I say it.
Okay, well, that's what we're going to say.
Yeah, okay. Yeah, Aduhelm, and this is a drug. It was approved by the FDA in June of last year, and surprised us.
Because I remember you were on the program then, and you were a little doubtful about the drug.
Yeah.
Are you still doubtful?
Yeah, I mean, it's one of those, there's data that says it might help. There's data that says it probably doesn't. And so we're sort of stuck in the middle. The FDA usually doesn't get out ahead and do things quicker than we want, right? And you hear a lot of criticisms there. And in this case, a lot of people are saying the FDA did this prematurely, and we don't really know. I think the best way to sum it up is 5 years from now, we're going to look back and we're going to say we should have used this drug in a lot more people, or we shouldn't have used this drug in anyone, and we don't know which way it's going to go. But it was approved, and that's a huge deal. It's been 18 years since we've had a new drug, and so it's a big step. Some people say it's in the wrong direction. Some people say it's in the right direction. We're going to figure that out over the next couple of years. It's out there. And another big thing that just recently happened was Medicare ruled on this drug and said, we're not going to pay for it unless you're getting the drug in a research study. And then Medicare will pay for it. So they really limited, how we can give this drug. And how to get it paid for, and it's really expensive. So
they're really asking for more data, right? Because when they do that, it's usually they're saying, we're not really comfortable with the data that's there. We want to see more information. As I remember, the panel that voted for Adhd was like a 5-4 vote. I mean, it was a split vote.
Well, yeah, so the scientists generally said they didn't buy it, and the FDA said, we think it's, they actually approved it on an accelerated pathway, which is sort of a partial approval, sort of a cautious approval where more data needs to come or they might pull the approval. And so, lots of controversy around it.
And the reality is part of it was because there weren't other good therapies for Alzheimer's. So they said, look, this is we're going to try this, and we'll see how the post-approval data looks, I think, is kind of what they were talking about.
Exactly. That's it. And we're sort of working that out right now. And we're going to work it out over the next couple of years, but I think it's a sign of hope. And we've been working hard for 20 years, and this is the first drug that really has come out, and it's a sign that we're making some progress, and there's more to come in the next few years. So anyway, so
now
hopeful.
One thing the FDA doesn't have to approve is exercise. So tell us a little bit about the role of exercise, because that's a big part of it, right?
Yeah. So we've been researching lifestyle for 20 years. We think, and I think now the broader field believes, that things like diet and exercise and even sleep and stress reduction, so lifestyle interventions, can have a big role in brain health. When we started, now I guess 18 years ago on this path, people weren't talking about prevention, and they weren't really talking about lifestyle. And now it's a different world, and there's a lot of data, and we've generated a lot of that data from our studies on exercise and diet that suggests that we can really have an impact on our brain health. Is it a cure? No, but I do think no matter what we come up with in terms of drugs, lifestyle is going to be important for brain health and be a part of what we do to maintain our brain health as we get older and prevent Alzheimer's disease and delay the onset if we're destined for it. So, and you might think of heart disease, where we have drugs, we have interventions, we have lifestyle, and that it plays a big role in reducing the risk of heart disease. We think the very same thing, is true for the brain. That we're going to come up with these drugs, we're going to come up with some prevention, therapies, we believe. And we also are going to understand better and better how to use lifestyle. And so I just say, exercise, eat right, and we think the Mediterranean diet is sort of right now.
Hopefully, those change from time to time. So
they do change from time to time.
I'm with you about that. Mediterranean. It looks like it has a lot of benefits and a lot of disease.
Yeah. So exercise, Mediterranean diet is a good pattern, and then take care of your heart. If you're taking care of your heart, you're taking care of your brain. And so that's probably the best we know right now in terms of prevention. So you've mentioned a lot of the research that's going on. What's out there? What do you hope is going to come? What's the next big thing? These drugs, understanding these drugs that are, or this drug now, and there may be more to come, is what's its true impact, in the disease, and then prevention strategies. And so if we combine a couple of things we've talked about, one is these markers. I mentioned blood biomarkers for Alzheimer's disease. Those are coming. And what we know about things like amyloid buildup in the brain is it starts decades before the onset of symptoms. So we can spot these changes before the onset of symptoms. And the key is let's do that effectively. A blood test would be beautiful and efficient, but then let's do something about it to reduce the risk. And this is what we've been working hard to do over the last 10 years is spot it early and then do something effective to reduce the risk. And I think that day is coming, and we're working hard every day to get there. But we need drugs, we need lifestyle interventions, we need things that we prove can effectively reduce an individual's risk when we spot that they're at high risk for the disease.
And so you still need more volunteers for that research?
Oh yes, I mean I'll tell you, this is true nationally. The number one thing that slows us down, people like me and researchers and scientists around the country, is volunteers for the studies that we're doing. There's nothing that slows us down more than that. We'll spend years doing a study. It might be, for an individual who joins, it might be a 6-month study or a year study, but it might take us 5 years to fully enroll that study. And so it's the rate limiter is how quickly can we find the volunteers and the study participants to join these studies. And we do a great job of it. We have thousands of people who've joined our studies, all from around the Kansas City region, but also across the state, from other states around us. And we just have amazing participation, but we never can get enough, I'll say that.
It's never enough, and you want more in order to get to the answers. So
yeah.
If you want to be a participant in the research trials Dr. Burns and his teams are conducting, how can they find you?
Well, you can find our website, kualzheimers.org, is a great way to find us, and you can actually fill out a form there to give us a little bit of information to get started and figure out what studies might you be eligible for. We have a large portfolio of studies, 30 plus studies, and there's everything from just coming in, sort of one-time deal, to joining a drug study, which is a big commitment that might last a couple years. And exercise studies, diet studies. So we have a lot of different things, and we're trying to fill all those studies. And it's a little complex in terms of figuring out what study might be right for somebody, but that's our job. So if you just call or go online, kualzheimers.org, and fill out that form, and we can get started in figuring out if there's a study that's right for you.
I like it, kualzheimers.org. It sounds like a really important thing to do. We're going to switch gears for just a moment. Hawk, welcome back, brother. How you doing this morning?
I'm good. How's it going?
How are we?
Yeah, we're good. The cases in the hospital still remain low in the single digits, 7 active infections, 2 in the ICU, but 0 on the ventilator. We had 1 on the ventilator yesterday, and 8 in that recovery period. So again, still holding for those active infections in the single digits, which continues to be a good thing as we have continued to see slight increases of the known and reported cases, but also increases in hospitalization, which continues to be much more important, I think.
I think that's right. In fact, let's take a look at a couple of New York Times graphs I think we've got. One is the hotspot graph, and then I think we got a graph on hospitalization. So you can see, it's been lighting up a little bit more. We've been talking about that for a few weeks, but we're all reading about the rapid rise in wastewater testing and in other types of testing with COVID-19. And now people are really, we've been talking on the program for a while, Hawkeye, that this is the BA2.12.1 variant. That's kind of getting a little bit more press now, but it's probably over 80% of cases, maybe higher than that in some regions.
Yeah, no, it's pretty amazing. Really the original Omicron is basically out of there. It's BA2 and then BA2.1.1.2, like you said. So it's the other one, but it's a combination of those for sure. And so I think right now we are in the period or the era of Omicron, and really what we're seeing is these new variants have really, what we have right now are really all offshoots of the original Omicron variant, which is really interesting for sure.
Let's look. Do you have that testing data or the one about hospitalizations and ICUs, et cetera? Yeah, this is a really important slide. I want to talk to you a little bit. So if you go back to February of 2020, so right at the very beginning of the pandemic, you can see each of the waves. There's been 1, 2, 3, 4, 5 waves in the U.S., and some people will count that first kind of double hump, maybe it was 1. But each of those were different types of variant: the original strain, the Alpha strain, the Delta strain, the Omicron strain. If you look at the gray zone, the gray line, this is actually the number of hospitalized patients. What we've said is it's the hospitalizations now that matter, because we don't do so much testing. It's basically at-home testing. It's not being reported. We really can't follow testing very well. The number of people who are positive, anywhere from 5 to 10 or 20 or even 100 times more than what we think it is. And so the testing levels are markedly underestimating the actual burden of disease in the community. But if you look at the graph at the bottom, so this is the number of hospitalizations. So hospitalizations are ticking up again, has us all concerned because we think that the amount of positive COVID out there is as high as it was in the Delta variant. But at the bottom is the number of ICU patients. And if you see what happens in the ICU, if you look at the rises in hospitalizations, there's almost always a rise in the ICU that travels pretty close together with the rise in hospitalizations. Not always, but pretty close. If you look at that bottom graph, the number of ICU patients right now is staying really flat. We got to hope that that continues, Hawkeye. That's good news. I think it's probably the impact of lots of vaccinations. So we've said before, you're not going to get hospitalized and be critically ill or die from this if you've been vaccinated. It's probably the effect of natural immunity because 70 to 80% of Americans have probably had COVID. And it's the effect of Paxlovid and other therapies we have.
Yeah, I think certainly, it is the effect of these past 2 years, both in the pre-vaccine era when we did have infections, now in the post-vaccine era where we've had immunization, which again is the safest way to get an immune response and immunity, and then also those reinfections. And so I think we are really seeing a cumulative effect of that on that individual person.
And we want that to stay low because you still don't want to get COVID, right? You say, well, I'm not going to be hospitalized, I'm not going to die. Yet, evidence came out yesterday from the CDC, 1 in 5 people under the age of 65 and 1 in 4 over 65 will develop long COVID.
Yeah, it's going to be a significant strain or issue for the healthcare system, the healthcare delivery system moving forward. It's going to be a significant strain for those individual people moving forward because we know about long COVID. We know how significant it can impact people's quality of life on a daily basis, whether it's being with their children, being with family members, or even going to work. And so moving forward, it's certainly going to be an important aspect of healthcare, especially in that outpatient setting.
Yeah, I think that's a really big deal. And if you step back and you think about the people who have long COVID, that's a little bit frightening. The other, and we have to deal with that on a long-term basis as a public and as a healthcare system. And we're being challenged already by the number of people who have long COVID. If you follow that up, the other thing that was that came out in the last day or two was information about gyms. I don't know if you saw that one, where people are spreading that when you exercise, the number of secretions you push out are between 20 and 100 or 200 times more than what you do at rest, suggesting that, no surprise here, that indoor exercise can be a hotspot. So we just have to be thoughtful of that as the numbers of COVID rise and as we still see long haul syndrome. Now, we don't know about the relationship between Omicron and long haul. So the numbers we give, 1 in 5 overall, 1 in 4 over 65 developing long haul, were applied to the entire pandemic. But my guess is that we're going to see it with Omicron just as we have with the others.
Yeah, and again, I hope that along with helping prevent hospitalization and death because of vaccination, hopefully moving forward we will see less of the long COVID overall compared to what we've seen prior to this.
Okay, fingers crossed. We got to hope that's true. We don't want any of the bad ways. People talk about stuff going to get worse in the fall. I don't know if that's true or not. I think it depends entirely on what happens with the variants and the level of immunity and vaccination. So stay safe, get your booster if you're over my age. I'm 62, so over 50. All right, let's continue our conversation. First of all, any reporter questions or any questions out there? Nothing? All right. We're going to come back to our conversation now on all things Alzheimer's disease. We told you earlier about, or we didn't, we were supposed to, I missed this part of the script. We're going to talk about a home test developed by the Ohio State University that anyone can take. You can find it by searching OSU Alzheimer's test, or you can use the QR code on the bottom of this screen to get to the website. That's kind of a big deal. You can actually do this home test. We're going to talk more about it. Print the test, answer the questions in ink without the help of others. So letting your 14-year-old, your 18-year-old, that doesn't score you, right? You got to do this by yourself. When you're done, take your answer sheet to your doctor so he or she can score it and talk to you about the results. I understand you use this test a little bit now to help make the diagnosis in patients.
So that is the test is called the SAGE test, and it's sort of a derivative of a lot of different tests, a variety of tests that are very similar, asking kind of similar questions, similar themed questions like, what's the date and draw something, and sort of a broad test. And they're screening tests, and we use them in the clinic. And this is one where you can do it at home and get a sense of how you're doing. It's okay to miss a couple points on that, but if you miss more than a few, it might be something you want to talk to your doctor about. And it can be valuable to use these. Now, we have a problem with screening tests, a couple problems with them, and so we push them, but not as hard as we might in a few years if we develop more interventions. But one problem is they're not that sensitive, and so meaning people can have significant memory issues and score pretty well on these tests, and that's sensitivity. And then they're often not that specific, which means it may point, in a variety of directions of what might be causing the memory issues. And so that's why they say take it to your doctor. Don't get hung up on a number if you do a test like that. Don't get too hung up on a number. It's important to sort of interpret it in context, and so you could talk to your doctor if you're worried about it. Do a test like that. All right.
Michelle, what do you think about these tests? Is this something that patients and families should try at home, or before if they have worries and concerns?
Well, I absolutely agree with Dr. Burns that there's some issues with their screening tests. They're not diagnosis. And there's many factors that impact the quality of that outcome and the usability of that outcome. So I say if you're noticing differences that are surprising, that needs to be an open conversation with your provider, and your provider needs to take that seriously and examine all the potential variables that might impact that. I am a believer that early detection matters in quality of life, and so it's important to pay attention to those changes. I would not get, as Dr. Burns said, panicked about the outcome of a screening test. There might be many explanations.
So can you kind of give us an example of what some of the questions are on the test? I'm not trying to prep for the test, by the way. I'm just kind of wondering what are some of the questions that are on the test?
There they are on the screen, and I think they're things like, what's the date? I don't know if what the types of that we ask on our screening tests, which are a derivative of this, are where are we, what floor are we on, what's the date, sort of orientation questions, a little bit of math questions, a little bit of memory questions. You might, I think in this one, you're given a few words and you flip the page and you're supposed to not look back and write down what they were. A little while later, drawn, you see a figure here where you're drawing a line from, I think it's from 1 to A to 2 to B, and you're alternating back and forth. And so it's a variety of things that really try to tap into, in an efficient way, memory, but also the other things that the brain does and the other things that can go wrong in Alzheimer's disease. So organizing and planning, language, spatial sense. And so these tests try to simplify that down so we can do it at home on a clipboard. And we do much the same thing in the clinic with similar tests, although somebody's delivering that, and we can do a little bit more, or a lot more actually, in terms of testing. So that type of stuff.
Michelle, I got to believe that when people get this type of diagnosis that they get depressed, and then how do we separate depression out from progression of Alzheimer's disease?
Mm-hmm. Wonderful question. Depression is one of the number one symptoms my team deals with when we're working with individuals. That depression makes everything worse, and you're absolutely right. It replicates in some way some of the symptoms that we see in Alzheimer's disease. So we look at a variety of symptoms, and we really parcel out in a specific way what those presentations are. And the goal is to address the depression first and to let people know that depression can complicate the picture, can present as worsening when really it is a resolvable issue. So we deal with the depression both non-pharmacologically, and we absolutely advocate for appropriate use of antidepressants earlier rather than later to resolve that issue. Again, the goal is maximum function. Let's be a warrior in this. Let's address every piece that we can address.
All right, so if I exercise like a banshee, can I slow the progression of this?
That's a big question, and we think yes. And there's a ways to go to really prove it. But if you have memory issues, we think exercising and just walking every day can help slow it. And then if you don't have memory problems, we think exercise can sort of push off and delay the onset for people or prevent the disease. So we think it promotes brain health and reduces an individual's long-term risk. So I'd say exercise.
Go for it. I
Yep.
like it. All right. Jess, let's see what community questions are out there.
Yes, we've got several for our guests today, but I do want to ask Dr. Hawkinson a question from Samantha. She wants to know, when should our kids 5 to 11 get boosted? Her kid is going to be involved in indoor-outdoor camps. She feels like she's hearing kind of mixed messages that she should or shouldn't. Can you help straighten her out?
Because the data that just this week comes out, it's looking better for boosters.
Yeah, absolutely. For the 5 to 11, we know that's a recent recommendation or authorization. And I believe it's at least 5 months from the previous dose or from their last dose. So at that point, any time after that, you can get that boost. We are moving out of school now, but we are moving into summer camps and things, and kids will be doing those types of things and interacting a lot with their peers. So it's really, going off of that recommendation and understanding that time frame, but then also understanding we know and have heard how many children have gotten Omicron over the past, this last surge. And so if that has happened, I would certainly recommend waiting, 8 to 12 weeks. Certainly the CDC recommendation is waiting about 90 days, so about 12 weeks. So any time after that 8 to 12 weeks is probably a good time to get that boost. Hopefully that helps answer the question.
He wants to know, how do you prevent or reduce the plaque and tangles?
All right. How do we get rid of those plaques and tangles?
Yeah. Well, we haven't, things like exercise and diet, we're not sure that they actually impact those plaques and tangles, and that's a big question that we're trying to answer in the research. The only way to reduce the plaques right now consistently is the new drug. That Adhd drug that we talked about earlier is designed to actually go into the brain and use the immune system. It's a monoclonal antibody against amyloid. So it sticks to amyloid, and then the immune system sees it and pulls it out of the brain. And it actually does that, reduces amyloid plaques very effectively. The debate about the drug is, does that translate into benefits for the patient? Observable benefits in cognition and function for the patients. And that's not totally clear yet, but we know we can reduce the plaques with that drug. But I would just say, the common sense advice for us right now, and the sort of the state of the art, believe it or not, despite all the work we're doing, is take care of your heart. What's good for your heart is good for the brain. And we think it, over the long term, has an impact on plaques and tangles and other measures of brain aging as we get older. So exercise, eat right, and if you're having memory issues, get evaluated. Early diagnosis is important. Those drugs that don't affect plaques and tangles are helpful. That Aricept and Namenda I talked about earlier. And then this new sort of era of potential drugs that can reduce plaques and tangles may be coming. And we're working that out right now.
If the disease has a 10 to 12-year runway, taking care of yourself up front, having your family take care of you, Michelle, is really important, because there may be new therapies that are developed in the next few years, so you may be able to be a beneficiary, but you got to keep yourself and your family's got to stay well in the meantime.
Yep. Right
Michelle,
on.
thoughts?
Absolutely. And I think it's that, let's stay in the driver's seat. Let's be proactive. Let's, identify problems as early as we can. Let's have open dialogue in our families and with providers. And, let's march on. And if we can slow it down any at all, then yes, we might be in a better position to benefit from whatever science offers us down the road.
I used to say this to my CF patients all the time. Do everything you can. You're buying another day. You're buying another day. You're buying another day, because new therapies are coming. And now, now it's a totally different era with new therapy, and you feel so bad for the people you've lost who didn't follow that, because they could have been a beneficiary. Jess, other questions?
Yes, several more. Here's one from YouTube. One of our YouTube viewers is asking, is neurodiversity, ADHD, autism, things like that, a risk factor for developing Alzheimer's?
Neurodiversity. I've not heard that phrase. I like that. Is that something you've heard?
No, actually.
That's kind of pretty. I may steal it.
Yeah.
I'm making my own. It's like Hawkeye.
So ADHD and autism, are they risk factors for Alzheimer's? Yeah, it's not that clear actually that it is. I'd say that probably not, and there may be reasons why we haven't sort of seen that yet in the data, but I don't see it a whole lot, although we have patients who do have some sort of distractibility and ADHD symptoms, but I don't think it's a real strong theme or strong risk factor.
Yeah, so what about heredity?
Well, heredity is important. It's not sort of definitive. It's not deterministic in 99.9% of cases. There's 3 genes that are extremely rare, and if a family has them, and you get that gene, you're going to get the disease in your 40s or 50s or 30s even. But that's extremely rare. And for the rest of us, if it runs in the family, your risk is a little bit higher. So heredity is important, but it's not deterministic. It sort of increases the probability, usually not greatly, but it's something that we sort of weigh into the whole picture.
Michelle, do you see families get really, not panic, but when one person in the disease, a mom or father, get it, and then they start, and then maybe and then they start, oh my gosh, am I going to get it? How do you work with people like that?
Yeah, and part of that is to just provide the information. We know there's various types of Alzheimer's disease, and as Dr. Burns identified, not all that purely genetic type. So part of it's giving information. But if you have any serious disease in your family, there is no possibility that it doesn't cross your mind, is it going to be me? And we don't know the age, we don't know the other variables that we can control, like lifestyle, like heart health. And so we have dialogue with them about that. And again, at the end of the day, it is important to live this moment, this day, this time frame as best we can. And that's true with everything.
All right, that ditto, yes.
Sharon and Corey have similar questions. Is a stroke or a traumatic brain injury a risk factor for developing Alzheimer's?
Yeah, what do you
Stroke
think?
or traumatic brain injury?
Yes, without a doubt, they're risk factors. Again, not deterministic in the sense that if you have one, you're going to get Alzheimer's down the road, but it is, those are risk factors. Both traumatic brain injury and stroke are pretty well described risk factors, where if that's happened, your risk is a little bit higher down the road. And I'd say it's even more important to take some action and be empowered, as Michelle's described. We need exercise, eat right, really focus on your heart health to prevent stroke, but also think about brain health, because when you're doing that, you're actually helping your brain in the long run. But yeah, those are risk factors.
Post-concussion syndrome from young athletes, soccer, et cetera?
Maybe.
It's
sort of the level of intensity of the brain injury, but sort of lots of those micro traumatic brain injuries can add up. It appears.
You see it like in boxing and things like that.
Boxing, and then with football, it's more the collegiate and NFL as the strong risk factors. High school, not totally clear, and soccer, kind of the same thing. Not totally clear at the sort of lower levels, but you get to the professionals, those headers and all, they can take a toll over time and put people at higher risk.
Jess.
Maggie wants to know, are there any over-the-counter medications that just help with memory, like Prevagen or Nariva?
So our take on those is they probably don't help. We're conservative with those, or agnostic. I tell people I'm agnostic on this. If you really believe in it and you really want it, I'm not going to twist somebody's arm, but the odds are very heavy in favor of what my mentor used to tell people: if you're taking those, you're probably just making your urine really expensive.
So the vitamin B6, antioxidant, super immune, hyperimmune stimulation, lymphocyte, none of that really, that's probably not doing a lot.
Probably not.
Yeah, that's what I tell my patients too.
There's probably some placebo effect.
Yes.
And I think we have to go back to that argument that people are so upset about pharma and big pharma and just out there to make money. My point is, if there was truly a drug that worked, big pharma would be on top of that and charging a very high price for that. It wouldn't be available just in the stores off the shelves for that reason.
It's right on.
I think that's one way to look at it.
Jess.
Okay, this is a very popular conversation, as you can imagine. So let me just sneak in 2 more questions. Kim wants to know if the doctor can explain Pick's disease.
You're going to do that one.
Well, so that Pick's disease is a form of dementia. I mentioned there's a lot of different causes of dementia, and Alzheimer's is the number one. Pick's is a cause of dementia, and it's in the category of frontotemporal dementias that affect different parts of the brain than Alzheimer's disease. In a different way, the Pick bodies are what are seen in the brain, and that's where the name comes from. But I think there was a Dr. Pick, but I actually don't know that for sure.
Oh, okay, we're staying off television. All right.
But anyway, it's a different form of dementia. It's very rare, but and very different than Alzheimer's. It affects social behavior and language often, so more than memory.
Jess?
Okay, 2 last quick ones. Fanny wants to know, what about the Exelon patch?
Yeah, so the Exelon Patch is like, it's a drug that's similar to the Aricept or donepezil that I mentioned. And so it's a cousin of that. It works very much the same, but in this case, it's delivered by patch as opposed to a pill.
And the last question is from Isaac. Do people that are still working tend to have less severe or slower progressing Alzheimer's? So if you're out there working and staying engaged in life.
Yeah, so that's another sort of big question, and it's if you keep your brain active, can you slow things down or prevent it? And there's some data that suggests working and keeping your brain really active can perhaps reduce someone's risk for the long term, and we're still working the details out there and the strength of that data. A lot of people retire because of memory issues, and when we do our studies, that can confound things, and it's hard to know what's driving what. But I think the message of keep your brain active, whatever it takes, but social activity, working, volunteering, but being active, reading, writing, being active, we think is helpful. And so add that to your list with exercise, diet, and keeping your brain active as something that you can do that will likely reduce the long-term risk.
I love this program. I bet we could go on for a very long time because these are great guests to have. But with time, we have to turn to get final thoughts. But Jess, we got to get him back on the program again because I've got a lot of questions I want to ask, and I know our audience has got to have a lot too. Let's have some final thoughts. Dr. Burns, we're going to start with you.
All right. Well, I'd say we're incredibly proud of where we are. We're just finishing our 10th year as a nationally designated Alzheimer's disease research center, one of 31 in the country, and we're pushing the research forward. We're also working incredibly hard to really grow the care that we provide the community through things like Michelle's Cognitive Care Network. And the other thing we're doing, working really hard, is training programs to train new scientists and doctors right here in Kansas City and attract new talent to Kansas City. And it's just an incredibly exciting time for us because of the growth in our programs, the growth in our science, and really moving the field forward. And it's an incredibly exciting time because of the way the field has changed really in the last decade with the promise of new biomarkers to spot Alzheimer's disease very early or even before the onset of symptoms, and then these new drugs that are coming and that we're a part of creating. So very exciting times. I think it's a hopeful time too for people who are worried about Alzheimer's and who may have it. So
it's a big deal. Michelle, Cognitive Care Network, that's got to be an amazing support structure for families and people who get this very difficult diagnosis.
Well, Alzheimer's is a team sport. That's the bottom line. And, families and individuals diagnosed are going to be best, do their best, and thrive best if they look at it that way. And if that means part of that team is providers, part of that team is professionals that can support and educate and help navigate, and part of that is expanding your informal base. And so our goal absolutely is we want to preserve as much function for as long as possible, be as well as you can, as long as you can, as independently as you can. And so you stay in the game, you assume this proactive posture, and you've got a community behind you.
Yeah, that's so important. My own experience has been our social worker is like one of the mainstays of our team because of treating the mental side of any disorder, any type of chronic disease is so hard, and it makes such a difference. So thank you for the great work I know you're doing. Thanks for being on this program. Thanks for bringing the message today, and I love that. Stay in the game. Hawk, final thoughts?
I mean, it's such an important topic. You know, just like long COVID is going to be a long-term issue for individuals, for families, for the healthcare system. We know Alzheimer's, these sort of cognitive diseases are going to continue to be that as well. I know my family's been impacted by it, so it's such an important cause, an important topic, and luckily we have people like our guest to help spread that message and try to evaluate and treat people as best possible.
You know, and I'll just tell you, I think this message about staying in the game and hanging in there and being part of research is so important. My dad had a cognitive disorder and dementia and Alzheimer's, and as you look down the road and you think to yourself, could that be me? Here's what you can do. Join one of these Alzheimer's research things that Dr. Burns mentioned. That is incredibly important. Thank you for the great work that you and your team are doing. This is a big deal. You guys having that Alzheimer's Disease Center here in Kansas City, that's really a big deal. And it's what we've said, and you've heard the message here again today. This intersection of faith, trying to do the very best you can to stay alive because hope will help with research to bring more science in order to bring the answers. And in my own life, when I started in medicine, the life expectancy of patients is about 15, 16, 17 years. Today, it's well over 40 years, and with a new therapy, we have no idea what it is. That's what we got to look for Alzheimer's. We know you guys are going to get there.
Right on. Yep.
Thanks for being part of this program. Thanks for tuning in. Hey, folks, we're back tomorrow. Don't forget, you can watch our shows anytime by logging on to the Facebook page or YouTube channel. We're back tomorrow with the Morning Medical Update. Have a great day, and remember, stay in the game.
Coming up tomorrow on the Morning Medical Update.
I'm Jill Chadwick on the next Morning Medical Update. How the contents of this backpack are helping injured athletes recover faster.
And I'm Alexis Del Cid on all things heart, why that backpack isn't the only thing needed to keep the hearts of young athletes healthy all summer. See you Thursday starting at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.